Welcome to NMQF's LinkedIn Live. NMQF is the largest minority health organization in the United States. Based in 1998, NMQF, the National Minority Quality Forum, is a nonprofit focused on healthcare research and education, and our mission is to reduce patient risk by ensuring optimal care. Today, we are hosting our LinkedIn Live. The intention of our LinkedIn Live discussions is to broadcast video discussions with experts in different fields to have hearty conversations about eliminating health disparities. And today, our LinkedIn Live will be focused on breast cancer disparities and delays in breast cancer care, particularly for people of color and minoritized patients. Today's LinkedIn Live is supported by our collaboration with the Academy for Continued Healthcare Learning. ACHL's mission is to design, develop, and implement quality continuing education activities for medical and pharmacy professionals across diverse practice settings that will have a positive influence on the way healthcare is practiced and improve patient outcomes. We're so excited today to talk about our collaboration, particularly in the context of ACHL's new Breast Cancer Quality Improvement Toolkit. And today, with me, I will have Dr. Nan Chen from the University of Chicago. Dr. Nan Chen is a board-certified hematologist, oncologist, who specializes in comprehensive breast cancer care. Dr. Chen's practice primarily focuses on treating patients with all forms of breast cancer. She has particular expertise in high-risk breast cancers, including metastatic, hormone receptor positive, and triple-negative breast cancer. Dr. Chen offers both standard of care, such as chemotherapy, targeted therapy, and endocrine therapy, and novel therapies through clinical trials in order to create individualized treatment plans for her patients. Dr. Chen, who prefers to be called Nan, hello. Please come to the stage.
Hi, Adjoa. Good morning. Thank you so much for having me. It's a great honor to be speaking to you today.
Yes, we're so excited to have you on our LinkedIn Live platform for a really great discussion that we're hoping particularly clinicians, health system administrators, and anyone across the health system really could gain a lot of value about how we can really address this issue of delays that we're seeing in breast cancer care delivery and ongoing disparities in breast cancer. I think the statistic is something like, whereas breast cancer cases may be reducing in prevalence, mortality is still high amongst women of color in particular. What is your understanding of the disparities in breast cancer right now that you've seen, and also that you've seen through your practice?
Absolutely. Breast cancer is the most common cancer that we see in women. And so this is a big women's health issue. We also know that minority women, especially African-American women, are more frequently diagnosed with more aggressive forms of breast cancer, as well as with breast cancer that's more advanced or in later stages, and oftentimes with metastatic disease. We know that these are disparities that will ultimately affect their mortality, and these are factors that lead Black women to unfortunately have a 40% higher risk of dying of their breast cancer as compared to their non-Hispanic white counterparts. This can be related to some of the biological features, as I discussed just now, but also, and even more importantly, to many social features of our society, namely that oftentimes Black women do not receive the same level of care as their white counterparts. And this can be due to a multitude of reasons, It can be due to health literacy, to socioeconomic factors, to transportation, to childcare. There are many features of our healthcare system that we can try to adjust and we can try to improve upon to really improve care for this group of women that really need it.
That's amazing. I mean, you really did highlight and talk about what might be the causes that we're seeing in the disparity statistics. What other, causes could there be? I mean, we've heard about challenges at NMQF regarding access to care. Um, but what kind of challenges have you seen in your capacity as a doctor at University of Chicago Medicine, in particular in Chicago, that could explain some of these disparities and delays in care as well?
Absolutely. So we know that the earlier we find your breast cancer, the best chance we have of curing it and the best chance we have of making sure it doesn't come back. Um, but if patients aren't getting their mammograms, or if there are delays from getting their mammograms to getting their diagnosis, we know that sometimes these delays can add up and these delays can affect outcomes. Some of the things that I have seen personally are women who have difficulty getting time off of work and so are unable to get their mammograms, of women who are caretakers for other members of their family, for their husbands, for their parents, and thus it is difficult for them to come in to get their care, or women who are mothers and who take care of their kids and who have a hard time coming in. Sometimes women will have difficulty with transportation. It will take them a very long time to get here, and thus it makes it harder for them to come in. Some women can be afraid of what a mammogram means and what a cancer diagnosis means, and that might keep them from coming in to see us. And so there really are a lot of features of care that are important and can contribute to delays.
Absolutely. So the U.S. Preventative Services Task Force made a major development and major announcement this year, um, updating the breast cancer screening guidelines and recommendations by lowering the age for breast cancer screening and mammograms, lowering the age of recommendation from 50 to 40. What would you say about this update? And how else would you describe it? What do people need to know about this update and how to communicate it?
So I think what a lot of this is driven by is some of the things that we've already discussed, that we know that Black women are more likely to be diagnosed with more aggressive forms of breast cancer at later stages of breast cancer. And so a lot of these guidelines are an effort to try to reduce some of these disparities on a national policies wide scale. Um, we would recommend that all women with average risk breast cancer should begin screening with at least a mammogram at the age of 40. And I say average risk because there are many women who are not average risk. For example, if you have a family history of breast cancer, your mother had breast cancer, or your grandmother had breast cancer, you have an older sister who had breast cancer, then you are not average risk and you likely should be screened at even earlier than the age of 40. And so the first step is actually to identify what your risk is and whether you should be getting breast screening at an earlier age than 40. In addition to that, we recognize that mammograms may not be the best screening tool used on its own for all women, and other tools that we have at our disposal, such as ultrasounds or MRIs, for high-risk women should also be used. And so that's another part of knowing your risk, is that we do know that Black women tend to have a higher prevalence of germline genetic mutations such as BRCA1 and 2, and women with these genetic mutations should also have screening earlier than the age of 40 and with more than just a mammogram. And so knowing your risk is the first step. I think that our national radiology organizations have started also taking steps to try to recognize that women's risk are different and that we need to be more aggressive in terms of screening women and at a younger age.
How do you think these updated guidelines will help to reduce the time between the screening mammogram and diagnostic mammogram to help reduce delays in
Yeah.
between those?
So everyone should start with a screening mammogram unless you have a breast abnormality that you're already presenting with, but otherwise everyone should start with a screening mammogram. I do think that, unfortunately, a lot of our insurance companies and the way that we are able to get these tests is driven by national guidelines. And so I'm hopeful that this change by the US Prevention Task Force helps our insurance companies understand that, we should be also paying for mammograms and paying for additional testing for patients that are younger. I also certainly hope that these guidelines provide additional resources for our radiology department and radiology departments all over the country to be able to provide additional radiologists to read these scans, additional techs, additional schedulers to reach out to patients and to make sure that nobody is falling through the cracks.
Well, yes, those are great points there. And certainly a lot to do ahead to ensure that the recommendations can be executed in a way that, like you said, could actually delay the delivery of these screenings. Moving forward, then, how do you think that these recommendations could also reduce the delays between a first positive biopsy and treatment?
So to be honest, once you have your biopsy, the bridge between there and treatment doesn't typically involve additional imaging all the time. But I will say that if we are screening women at earlier stages of disease, then hopefully we can potentially offer them less aggressive treatment. And then, they'll have a better chance of cure with the treatment that we offer. And so I do think that these guidelines are helpful throughout the entire care continuum from diagnosis to treatment.
Yeah, you mentioned earlier about how African American women in particular can have more aggressive forms of breast cancer. And at NMQF, we really are concerned about the fact, and you mentioned it, that African American women tend to have aggressive forms of breast cancer, and we're hoping that earlier screening and earlier detection of breast cancer with the updated guidelines could also mean catching breast cancer at earlier stages, and so that the treatment could be more successful, for survival. So
Absolutely.
good news all around, though. But
Hopefully, yes.
much to do.
Yes.
Hopeful, right? So, a big piece about of these updated guidelines is communication and making sure that clinicians are communicating these changes in a way that prevents confusion and encourages routine care and encourages adherence. And that's generally what's necessary in order to prevent delays in breast cancer care. How would you advise clinicians like yourself moving forward with how to communicate, particularly with patients of color, minoritized patients, when it comes to breast cancer care?
So receiving a breast cancer diagnosis is always a very traumatic experience and oftentimes one of the toughest times in a patient's life. And so I think approaching all conversations with patients from a place of compassion and empathy and recognizing that even though they're here in your office to talk about their cancer, that there are oftentimes other things going on. I mean, the number of patients I have who are they themselves going through chemo, but also taking care of a parent with Alzheimer's or taking care of a husband who just had surgery is astounding. And so there are many things going on, and we have to recognize that our patients are full people and not just cancer patients and not just people with cancer. In addition to that, I think recognizing some of the barriers to their care, to African American women care that is not always present. Some of the ones that I've mentioned previously, like transportation, getting time off of work, changing jobs and thus changing insurance, childcare, health literacy. Many of my patients don't always have the family support that I wish they had when they're going through an experience like this. And so I think trying to incorporate a lot of those areas into your care is really important. I reach out to my social worker probably on a daily basis to kind of talk about what other resources are available to help our patients. We have a really robust nurse navigation program here at the University of Chicago that can also help us with things like transportation, and other logistical ways to help our patients. But I think that, in general, leading with empathy and trying to do our best for this vulnerable population is really important. And also explaining, while patients may be diagnosed with an aggressive cancer, it doesn't mean that there aren't options. It doesn't mean that there's nothing we can do. And so making sure that they understand the full breadth of what the medical options are available in 2023 for breast cancer. And there are many for everyone.
Yeah, and there's so many resources now, both in person and digital. How would you advise clinicians to integrate in-person and digital resources to improve patient navigation of breast cancer patients?
I think that one of the silver linings of the COVID-19 pandemic is it really expanded the idea of using telehealth. And I think for patients who, if you don't have to do an exam and you are able to see them over the video, I think that video visits are a really great tool to reduce patients' time in waiting rooms, to reduce patients' time in transportation, to reduce patients' costs for transportation and parking and gas. And so I encourage clinicians everywhere to really think about what patients are appropriate for telehealth and then to use it widely, if they can. I will also add here that telehealth in of itself is a service that not all patients have availability to. I think especially for older patients who may not be as familiar with some of the newer technologies that we have, while telehealth is available, they may not have access to it as much. And so again, providing resources and providing time and financial efforts to try to provide education for that patient population and still make sure that they are not left out of this important medical revolution.
So important. And you did mention digital literacy as something to be cognizant of, especially as we still have a digital divide in this country. So important, particularly for some of our minoritized patients, for sure.
Yeah, absolutely. We also communicate with our patients a lot through, online portals and chats. And I think for patients who that isn't an option, it also creates a disparity and disadvantage in that they don't have as much access to their provider as other patients might.
That's wonderful. That's wonderful. So the University of Chicago Medicine Comprehensive Cancer Center Breast Department, the University of Chicago Center for Continuing Medical Education, and the Academy for Continued Healthcare Learning did compile some tools and resources to form a quality improvement initiative. Can you talk a bit about this initiative, these resources, this toolkit, and how it's put together and what it is designed for?
Yeah, so we know that nationally, there are healthcare disparities in breast cancer that adversely affect African American women. It is a very, very large project to tackle. And so we wanted to kind of start at a local level and saying, in the Chicagoland area, in Cook County, could we positively impact breast cancer outcomes in our African American community with interventions that we do at home in our backyard? And so that's really the foundation of the toolkit. And in this toolkit is really some videos. There is a video describing disparities in breast cancer screening. specifically looking at data in the, again, Chicagoland area and the University of Chicago catchment area. There is a video looking at disparities in breast cancer treatment, as well as a health equity panel with members of University of Chicago, as well as some of our other local partnering institutions, as well as patients, examining really how health equity looks like for them and what are ways that we can do better. In addition to this, we also have handouts and templates and other tools that other healthcare systems and clinics can use in order to really try to address this important issue.
Yeah, and my understanding is that the goal of this initiative is to look at the patient journey for breast cancer care and identify where the delays are happening, as we just discussed, and how we could intervene, right, with the use of the toolkit. Is that what you would expect with the toolkit?
Absolutely. Breast cancer journey is a marathon. It is not a sprint, and it's important to maintain engagement with your patient and with your clinician the entire time. We looked specifically at two areas that we thought we could both measure and we could improve on, and we thought that these were two areas that could significantly impact patient care and improve patient outcomes. The first one is looking at the time it takes between an abnormal screening mammogram to a diagnostic mammogram. The diagnostic mammogram is the next step in basically evaluating that we need a biopsy and we need further workup of this abnormal screening finding. Sometimes, as we have noticed, women are going for months between an abnormal screening mammogram and the next step. And in that time, things could be changing with their cancer. It could be becoming more advanced. And really, again, early intervention is the key to really trying to improve breast cancer outcomes. The second marker that we are looking at is the time from a breast cancer diagnosis, and so a positive biopsy with breast cancer, to the time of initiation of treatment. We are aiming to reduce that to about 30 days so that women who have a positive breast cancer diagnosis aren't, again, waiting months to start their treatment, and they can begin treatment and begin their journey to curing their breast cancer and treating their breast cancer.
Yes, and you mentioned that this was really developed at the local level in Chicago. Describe that process of that. Were you using sort of real life examples that your practice has seen to inform the toolkit?
Absolutely. So we are actually using real world data at the University of Chicago that has been collected over the past 2 decades, looking at our rates of delays in screening and delays in treatment. And we are evaluating whether some of these interventions, such as the 2 videos and the other educational products that I described earlier, would be able to potentially decrease these delays.
Right. And regarding the videos within the toolkit, what were those like, and how was that put together? And what is the purpose of them? How are you all encouraging future discussion regarding the toolkit and the interventions and strategies discussed?
So we really wanted to provide an educational foundation for the providers here, and as well as the nurse navigators, the community health workers, really anybody who has interactions with our breast cancer patients. And it's not even just inside of the clinic, because there are many people that work with patients outside of the clinic. We also partnered with other local public health organizations, patient advocates. So it's really a wide group of people that we are hoping to reach out to with our videos. These videos are really to provide a foundation of data to establish both the existence and the severity of healthcare disparities in breast cancer screening and treatment nationally, but also in the local Chicago area. And so the goal of these videos is really to provide this information so that everyone working with breast cancer patients can understand kind of the severity of the problem and ways that also we can potentially tackle social determinants of health, ways that we can tackle our own biases, and ways that we can tackle some of the injustices in our own local system to try to overcome some of these barriers.
That's amazing, local and national. So what you're saying is that these strategies could be implemented by any healthcare system and any clinician across the country.
Yeah, I think that there are many commonalities in what we are doing here versus what folks are likely dealing with in New York and in Houston. But also, I think we fully recognize that Chicago is also not New York and Houston, and we're not in, other areas. And so there might be some, specificities about what we're looking at. For example, we are in a very urban environment, and so public transportation is very available for our patients. But in rural areas, public transportation is probably very difficult to get to, and so that's something that would be unique to them. But in urban areas, we also see a lot of other unique features that we may have in common with other cities. And so I think it's really about taking what you can from the toolkit and trying to apply it to your own local situation. I think at the end of both of those videos, we kind of discuss some larger ended questions about, what do you think you can do personally in your role in the healthcare system to really try to reduce disparities? How can you better interact with your African-American breast cancer patients? And what unique things have you seen in your patient population that you think you can improve on? And that's going to be different at each place. And that's going to be different even for each person.
Yes, but I will say at NMQF, we certainly have seen with our working community through our Cancer State Shifting Initiative, what you just said, that there are commonalities when it comes to disparities in care, despite the settings in regards to implicit bias and some of the access issues as well. So we really are encouraged by the thoughtfulness that went into the toolkit and the strategies that it could be impactful. Speaking of impactful, has the University of Chicago used this toolkit within its own system? What impact did you see, if you have, and what impact could folks expect from this toolkit?
So we implemented this toolkit in the last 12 to 18 months. We had talked about kind of using our own University of Chicago data to evaluate, our history and how we've been doing, as well as the impact of the toolkit. We are still in the process of analyzing our data because, given that we've implemented it, now we're kind of looking at what we're doing right now in real time. I certainly hope that other centers can use this toolkit in a similar way. We are specifically looking at delays in time from screening to diagnostic mammogram, as well as delays in time from the positive biopsy result to treatment. And we think that these are also measures that other health centers can use to try to evaluate how well they are doing in terms of patient access and how quickly they are getting patients into clinics and into the appropriate care. Certainly at the University of Chicago in the last year, we have done a few measures that we think are hopefully impacting our patients. First of all, we have really tried to pilot an effort to get new cancer patients into our clinics within 7 days. So that way patients, can meet with an oncologist and can receive a plan for their cancer care as quickly as we can. Secondly, we have expanded our nurse navigator program within the breast center. Our nurse navigators actually call patients before their first visit just to introduce themselves and just to kind of give them a little bit of an idea of what to expect. Obviously, it's really difficult to tell them everything that they're going to discuss. But we hope that it provides at least a little bit of a welcome so that they're not so overwhelmed on their visit. These nurse navigators are also present for the patient throughout their journey in the care, which means that they speak to patients before they meet their oncologist. They continue to follow patients throughout their treatment journey. And even as they go into survivorship, which, is our hope for all of our breast cancer patients, is that they go into survivorship. And then lastly, within our cancer center, we've expanded our community health worker program. And these are really ways for us to we fully recognize that as clinicians, we cannot provide all support for patients. Unfortunately, we don't have the resources, and we're also just not the best people to do that job. We have community health workers that are actually community based. So, I mean, they work for the University of Chicago, but they exist in the community. They're able to visit patients in their homes. They're able to call patients more frequently, and they can oftentimes help us identify areas of patient need that sometimes we miss or sometimes that we're not able to cover. So, for example, if patients, if a walker is broken, or if they realize that a patient needs maybe a little bit of physical therapy, or if they recognize that maybe a patient is losing a little bit of weight and may need additional nutritional resources, they've been really helpful in helping us identify some of that. And I feel like they're a really good resource for patients. I mean, these are people who live in the same community as our patients. These are people who, go around with them, and they can help us say, oh, you should go to that local grocery store because they're having a sale on, this really great protein drink that you should be having. Or, oh, I heard about this taxi service that, gives discounts. And so they've been really helpful in that aspect as well.
That's amazing. That's amazing. Um, my understanding is that they're hoping, the collaborators of this project, to achieve other outcomes, and impact via the toolkit. Could you describe what those are in particular in relation to even, participation in clinical trials, about strengthening, the relationships between clinicians and networks, maybe sharing of information and best practices. What is the hope of the toolkit as far as impacting across the continuum of breast cancer care?
Yeah, clinical trials is a great tool in our ability to treat breast cancer patients, especially those with advanced disease or aggressive disease. Um, I think that not everybody may know how to speak to their patients about clinical trials, and especially maybe African American patients. When it comes to clinical trials, there's a specific set of concerns that the community has that are valid and need to be addressed appropriately. Um, African American women will go on to clinical trials just as frequently when asked as their white counterparts. However, our research has shown time and time again that they are not appropriately represented, especially in diseases where the incidence and prevalence in African American may even be more than in white women. And so it is truly of the utmost importance in the oncology community and in the general medical community to make sure that we are accurately representing the demographics of our disease, and we are putting in extra efforts to recruit minority patients and African American patients to our clinical trials. At the University of Chicago, we have a wide group of clinical trials that we are able to offer to our patients. We are always happy to see patients or interact with other clinicians to find out if there is a clinical trial that is appropriate for them. I frequently see patients in my clinic specifically for clinical trials that maybe their local oncologist, doesn't have at their fingertips. And so I think this is one of the strengths of our program and something that we can offer as a service to the rest of the Chicagoland area, to the point about strengthening our relationships with local providers. First and foremost, we just want to make ourselves available for, concerns, and we want to make ourselves available for patients. We want patients and their providers to know that this is a resource that you can use to improve patient care. And so we really have been working both looking at in the suburbs as well as in other areas of Chicago to really try to expand our footprint just to as a resource for others.
The Breast Cancer Care Team at the University of Chicago Medicine, the University of Chicago Center for Continuing Medical Education, and the Academy for Continued Healthcare Learning embarked on a quality improvement program to explore how targeted educational strategies and interventions applied at a local level can improve various facets of breast cancer care for African American women treated in Cook County. Throughout this journey, we compiled tools and educational resources that supported our goals of reducing delays between an abnormal screening mammogram and a diagnostic mammogram, as well as delays in treatment initiation after receiving a positive biopsy. These resources have been organized into an online digital toolkit available for use by individual healthcare professionals or breast clinics to address disparities in breast cancer care. You can find these resources at toolkit.fightingbcdisparities.com. Let's explore the contents of the toolkit. Are you interested in targeting quality improvement goals in your setting? If so, you can leverage the QI Implementation Tools section and begin by reviewing the implementation instructions that align with the Institute for Healthcare Improvement's Plan, Do, Study, Act model of quality improvement. Next, establish your quality measures and determine your data sources. Next, access the driver diagram template to support setting aim statements and specific change concepts. Then use the action plan template to develop a plan to test your change concepts. QI tools not for you? Perhaps you're interested in educational interventions that include workshops and practical resources you can take back to your team. You'll have access to 3 educational workshops that were conducted and led by Dr. Chen, Dr. Olapade, Dr. Ganchow, Dr. Peak, and Ms. Battle for the breast cancer care team at the University of Chicago. These topics of the workshops include screening and diagnosis, treatment, and a health equity panel discussion. Downloadable materials aimed at mitigating disparities in screening, diagnosis, and treatment provide practice change strategies and recommendations covered during the facilitated workshops. These include actionable steps such as broadening the role of nurse and patient navigators, utilizing patient health management tools such as electronic health record systems, and establishing community outreach initiatives. Lastly, a number of carefully selected supplementary resources were compiled to provide a centralized repository for both breast cancer disparity resources and tools that can be shared with patients. Whether you're looking to revisit workflows to better support your patients on their breast cancer care journey, or looking to establish targeted quality improvement goals that will address disparities within your practice, this toolkit provides enhanced clinical training and continuing education resources that can effectively translate research about what fuels disparities into actionable change. Access these resources today by visiting toolkit.fightingbcdisparities.com.
Thank you so much, Nan. This has been a wonderful discussion about how we are meeting the fight. And I just want to, again, remind everyone that you can visit the tools that we discussed with the breast cancer QI toolkit that was so thoughtfully developed at toolkit.fightingbcdisparities.com. Again, that website is http://toolkit.fightingbcdisparities.com. I'm sure the University of Chicago would love to continue to collaborate with other providers in the area to advance the toolkit and the strategies that were discussed. At National Minority Quality Forum, we will continue to work with the Academy for Continued Healthcare Learning to raise awareness of the strategies that were outlined and presented in the toolkit as we try to meet the concern and continue to raise hope and awareness of new tools and resources and new strategies being employed to reduce disparities in breast cancer care and delays in screening and treatment. Thank you again for your time today, Dr. Nan Chen. We hope to have you back on our LinkedIn Live program for future discussion, perhaps with all the success we will continue to see with implementation of the toolkit.
Thank you for having me, Adjoa. This was a real pleasure to talk to you today about this really important topic.
Thank you too. And we'll invite everyone, our listeners and viewers, so also return to our LinkedIn Live platform, subscribe to our LinkedIn page at National Minority Equality Forum to get future updates of our LinkedIn Live program. Also visit www.nmqf.org for our newsletter, sign up for our newsletter to get further updates as well. Thank you so much.